I knew that I wanted to do surgery when I qualified from medical school, and I don't really know the reason why that happened, but I just generally found myself more excited by the surgical side of things rather than the sort of medical physician side of
Yeah.
things.
Yeah.
And then I did all my sort of basic training and general surgical training. And my first job as a registrar, which is quite a senior training position, if you like, before consultant. My first consultant, um, who I worked with, she did bariatric surgery, and she was an absolute inspiration. You know, the way she talked to patients, the way she understood the problem, you know, understood the disease that is obesity,
Mm.
and the way that that translated into her care, and you know, the technical side of the operations being so complex and challenging. It was just absolutely, you know,
Mm.
as soon as I started working with her, I was like, I have to do bariatrics. And
Inspired.
ever since the day I met her, I've stayed in touch with her. And you know, we've worked together collaboratively, and it's been wonderful. And I've never looked back. You know, bariatrics is the specialty
Yeah.
that
Yeah.
I will retire on eventually.
Oh, fantastic. Yeah, that's really good. An inspiration. So what you have got lots of accolades to your name.
Yes, yeah. Well, we've worked hard. I don't do anything in isolation. You know, I'm very much part of a team, and our team is very well recognised. In the gastric balloon side of things, the Allurium balloon, we are the only UK centre of excellence for the procedure, and
Okay.
that's down in no short part to the team around me.
Mm.
And you know, we've got the dietitians who are world class, and we've got Sophie, who's actually my wife, and she
Oh,
runs that practice and knows the product inside out, and she's been fully trained on it. So we've got that accolade. We've got lots of patient experience awards. We get a lot of uh, accreditation for our patient experience. And personally, throughout my training, I was trainee of the year twice, and hopefully that's continued on to consultant practice.
yeah. Oh, that's great. Now, you specialize, is it in the balloon?
So we do weight loss surgery, or sorry, we do interventions for weight loss,
Yeah.
and that includes surgery and the gastric balloon. So the balloon is not surgery, but it's part of what we do.
Right. Okay, then. And obviously, you do other surgeries as well. So you
Yeah, so
do
we do
sleep.
gallbladder surgery, we do sleeve gastrectomy, we do gastric bypass.
Mm.
We no longer do gastric band. That seems to be a sort of historic operation now worldwide.
It does seem to be, doesn't it?
It,
I've heard that
it
quite a lot, actually.
yeah. I mean, the worldwide figures are now less than 1% of all weight loss procedures banned, and
Mm. Mm.
most countries around the world have abandoned it. And there are lots of reasons for that. And we could talk about that at another time. But
Yeah.
yeah, and I also do surgery for heartburn, anti-reflux surgery.
Yes. Tell
Um,
me about that.
well, I
Because
mean
that's a
that's
lot of people get obviously the reflux, not just because of
yeah,
obesity, but literally, anybody. I think
yeah,
lifestyle as well, bad lifestyle, drink and bad food
yeah.
and
I mean, the reflux heartburn side of things is a bit like you know, patients who live with obesity, in terms of there are lifestyle components that can be improved, but
mm,
ultimately there's an underlying problem that is beyond the reach of most lifestyle
mm,
interventions.
mm,
So, for example, you know, with reflux, it's often because you have something called a hiatus hernia, which is where your diaphragm has split apart and your stomach has gone up through the diaphragm. So we can, you know, you can cut out smoking, you can cut out drinking, you can eat a low calorie diet, but that's not going to correct the physical problem that is the
mm,
hiatus hernia. So we do surgery for that. And the same, you know, people living with obesity, you can do a low calorie diet, you can exercise more, you can eat smaller portions, but ultimately there's an underlying metabolic disease, and that's not going to fix it. And that's where weight loss surgery really comes into its own, is it can help fix the underlying metabolic disease.
mm, mm. Yeah, okay. So, and then you operate obviously to the hiatus hernia, and then the reflux will just literally go.
So there are two components to it. So you have
Mm,
to recreate the anatomy back to how it was intended, and then you
mm,
have to create a valve, like a one-way valve, to allow food to go in, but acid not to come up. So that's called a fundoplication, which is where we wrap the stomach around itself. So you
right.
close the hole
Yeah.
and you wrap the stomach around itself to create a valve. So two
Oh,
parts to the
okay.
operation.
Because obviously with the sleeve, lots of people get the acid reflux, don't they? Why is
Yes.
that? Why is that then?
Well, good question.
Aha.
A very good question. So basically, with a sleeve, you are changing your stomach, your big baggy sack of a stomach,
Mm, mm,
into a tight tube. So the pressure within your big baggy sack of a stomach is low pressure. And then when you make a tight tube, you are suddenly creating a high pressure tube. So if you are already a little bit leaky at the top end of your stomach
mm.
into your esophagus under low pressure, when you put that under high pressure, you're going to leak more, which
Makes
therefore
sense.
makes you more vulnerable to acid reflux.
Mm.
Um, and that is very crucial in deciding which operation somebody
Which,
should have. So
yeah.
if you have pre-existing acid reflux to the point you need daily medication, you probably shouldn't have a sleeve because you're at risk of making that worse.
Mm, mm. Do you know what? I was supposed to go in for a bypass because I had really bad yeah,
Yeah.
reflux, and but he couldn't do it for some reason. I don't know why, but he couldn't do it. Something about being too fatty and it was too to the wall. I'm not quite sure. I don't know the mechanics, but he had to do a sleeve. But
Mm.
I was so lucky because it went. It literally
Yes.
went. So I was so lucky because that could
Yeah.
have been really bad for me. But
Yeah.
no, I was really lucky.
So it's definitely a risk. And the other thing is that often people who live with obesity who come for surgery, often they have an undiagnosed hiatus hernia. So you already have a gap in the diaphragm.
Mm,
And then if you put a sleeve on top of that, then the reflux can get out of control. And the problem with a sleeve is that there's a huge number of advantages with the sleeve, don't get
mm,
me wrong, but the problem with the sleeve is it's irreversible. So once it's done,
that's
it
it.
can't be undone. So in order to get you out of crippling reflux after a sleeve, you would have
Mm.
to have probably a conversion to a bypass.
Aha. Okay. Yeah, that makes sense. That makes sense. Now going back, um, now it's the pill balloon,
Mm,
Allurian. Is that
yes,
right? So
it
tell me
is.
about that one
I got it here.
because I've never heard of it. Oh, there. Okay.
So
I've never heard of that one.
this is basically a little capsule, which is the
Okay.
size of the tip of my finger. So it's not big.
Hmm.
And basically, what you do is you swallow that in the outpatient clinic. So you basically have a glass of water, swallow that down, and this tubing goes down with it once you swallow it.
Mm,
Then we take an x ray, make sure it's in the right place. And then with this
mm.
hanging out of your mouth, we connect it to a bag of fluid, and that capsule melts and then expands, and it expands into this.
Wow. Okay.
So basically, you're turning the grape into the
Yeah.
grapefruit.
Yeah. Yeah.
And this basically is fluid filled and sits in your
Yeah.
stomach. And at 4 months after it's gone in,
Yeah.
this automatically opens up
Yeah.
and the fluid empties, and then you just pass it out. So there is
That's
no
incredible.
removal procedure.
Yeah. Oh,
So
that's incredible.
it's incredible technology. And all other gastric balloons, you have to put in with a camera and a general anesthetic, and you have to remove them.
Mm.
That technology is just old fashioned now. This is the
Mm.
modern way to deliver balloon therapy. Uh,
Yeah.
and the balloon is just the tool, a bit like surgery. It's just
Yeah.
the tool. You've got to work alongside it. And during that 4 months, you have a very intensive dietitian led training
Mhm.
program with a lot of technology as well. There's apps and scales and watches and various things, so you can monitor your progress. You can get input to change your dietary habits, and the idea is that once you have done that and then the balloon goes, those changes are sustainable.
Yeah, and of course in 4 months, because I found obviously with my surgery, you get into a routine anyway. In fact, you
Yes.
probably get into a routine sooner. So
Yes.
mentally, physically, you are into sort of the routine. So
Yes.
I'm presuming with that tool, you would definitely continue.
Yes, and what's really important about it, and it's not this that's important. It's the program. It's the daily checking in with your calorie control, your portion size, getting input from a professional, and that level of training and the results are motivating, so that people often don't want to go backwards. So when it's gone,
Yeah.
they don't suddenly revert to old self. They want to continue that journey. So often we see people continue to lose weight after
Yeah.
it's gone.
And is there any side effects?
So it's a very safe thing. The risk of complications is very, very low. But what we find is that 3% of people can't tolerate the balloon. So they basically won't settle. They continue to feel sick, and we have to remove the balloon. So there is a 3% risk that you won't be able to tolerate it, which means 97% of people will. And
which is a good percentage.
It is a good percentage, but the expected weight loss is around about 10 to 15% of your total body weight.
Okay, so that's good as well.
Yeah. So it fills a gap that where people are not eligible for surgery. So you can have the balloon BMI 27 and above, whereas surgery is 35 and above.
It is, yeah.
So it fills
27,
that niche.
27 BMI. Oh, okay.
Yes.
Okay,
Yeah.
so that's good as well. That's good to know, because we get a lot of questions like I do get a lot of questions like how what BMI do you have to get in order to get the surgery, because they are lower.
Yes. So the UK guidelines is 35 and for surgery, and that is purely for safety reasons. So 35 is considered the point where the risk and the benefit is in balance. Below BMI 35, the risks of surgery are considered too high, and this is why it's very upsetting when you reject somebody for surgery on the basis of safety grounds, and then they fly abroad and get surgery because there's no regulation or there's no rules around that. So it is for safety reasons, and surgery cannot be taken lightly. It's low risk surgery, but it cannot be taken lightly.
A lot of people do go abroad now.
They do.
Yeah.
And the real problem with that is not that the surgeons are a problem. The problem is there's very little aftercare. And just as we said with the balloon, the surgery is not the most important part of your weight loss journey. It's the psychology, it's the aftercare, it's the dietitian input, and you cannot change what might be 20 or 30 years worth of problematic eating and problematic drinking sometimes without doing the work afterwards. And surgery won't fix that. Surgery will not fix that. And I'm a very passionate believer that surgery won't work without those things.
No, absolutely not. So going into that, what's your aftercare? I bet it's fantastic.
Yeah, so we're very, very proud of our aftercare. So we basically run, for surgery, we basically run a 2-year fixed thing, which is where you have daily calls for the first week, and then a physical review at week 1. And then you see our nurse every 3 months, you see our dietitian every 6 months, and you see our psychologist at a year. And then we have a lifelong support group online where all the patients are there. And, even our patients 8 years post-op are still active on the group, and we're still, know all about their life and their marriages and their, dogs.
Oh, that's great. Everything. I love that.
So it's a real community, and that is wonderful, because when people are struggling, even 5 years post-op, They
Yeah.
just put out a post and say, guys, I'm struggling, and then everybody floods in and supports them.
Yeah, yeah. Oh, I love that. That's really good. I like the fact that there's a community, as you say, in groups, and they all talk, and because
Yeah,
you do need the help, afterwards, and
100.
you do, mental side of it, and keep going, and if they start to put a pound on, they sort of panic and go, oh, I'm going to
Yeah,
regain, I'm regaining, and sort of help.
yeah. But what you realize when you have a big community that is overseen by the professionals is that actually things that they're worried about are normal. So, for example, regain is normal to a certain extent, and actually, in many cases, we want you to regain a little bit because what you've got from your lowest weight is probably not your healthiest position to be in.
Mm,
So, actually, regaining a stone after a 12 stone loss is probably your body saying, I want to be at this level, thanks very much, I don't want to be at that
yeah,
level.
yeah,
So
yeah.
but they're panicking because they're regaining.
That's absolutely true. I get so many people, again, how do I reset? I've gained
Yeah,
12 pounds. What am I going to do? How am I going to
yeah,
set it?
yeah.
That is
So
a very, very common question, actually, and very common for people.
yes, and making the clear point that the number on the scales is not the end goal. The number on the scales is actually something we can document and something we can talk about it, but actually feeling better in yourself, having more self-esteem, having the ability
Mobility.
to, having the mobility, having the ability to apply for that job you never thought you'd apply for. These are the crucial, non-scale victories that
Mm,
we should be focusing on, not
yeah,
being obsessed about a number on a scale.
yeah, absolutely. Yeah, I'm a bit obsessed by the scale. I've got to
Well,
admit.
everybody is, but the problem with that, and I know how hard it is because all of my patients say exactly the same thing. But the problem with that is it harks back to a previous life, the previous dieting life, where you were so disappointed and broken every time the scale said the
Mm,
wrong thing.
mm.
And what we want you to do is to draw a line in the sand. And we ask our patients to bin their scales and only weigh when they come to clinic.
Aha, okay. So shall I bin the scales?
100%.
Okay, I'll try. So we're coming to the end of my questions. Lastly, for me, tell the viewers what hospital and where you are, so where they can find you.
So I work out of Spire Gatwick Park Hospital, which is 5 minutes from Gatwick Airport, which is actually wonderful for us because we attract patients from all over the UK. They fly in for
Mm.
their surgeries. The best way to contact me is through Instagram, I think, at Weight Loss Surgeon. So if you follow me on Instagram, then you've got my links in the bio and you get to my website and etc. That's where I put all my education stuff and our
Mm.
patient reports, etc.
Yeah. Oh, that's good. Social.
Yeah.
That's really
Well,
good. I've seen your Instagram. It's amazing.
the thing about my field is you've got to reach the people who need the help. And the way to reach the people who need the help are to indulge yourself in that environment and
Hmm.
also understand what people are going through. So if you can
Yeah.
understand what it really means to live with obesity, and I can't understand that from a personal perspective, but I can understand it from my experience of being around people who live with obesity. So I
Mm.
really
Mm.
believe that me and my team understand the challenges. And if
Mm.
you understand the challenges, you can help work on the solutions.
Mm. Mm. I agree. I agree. Absolutely, 100%. So I've got a few questions because obviously I've put out that we will be interviewing and we will speaking to you. So I have got a few questions actually from a few people.
Sure.
So Samantha, you asked, can you stretch a pouch, which everybody asks.
So the simple answer is yes, you can. Um,
Yeah.
if you have a sleeve, what is nice and tight on year one is not going to be nice and tight on year three. And part of that is just normal wear and tear.
Uh-huh.
And another part of that is you might have been overeating, or you might have been overdoing the fizzy drinks, because gas in fizzy drinks can really stretch up the pouch. So we try and put a ban on fizzy drinks if we can. And if you eat beyond fullness every time,
Mm.
you are going to, if you rely on that feeling like the chest pain and the fullness to be your cue to stop, you will stretch your pouch. So you have to try and get to the point of eating before you get those stop signs.
Yeah.
And with a bypass, it's less of a problem if you stretch the pouch, because there are multiple mechanisms that are contributing to the weight loss. Whereas with a sleeve, it's very much centered around the stomach. There are other mechanisms, but once that stomach restriction has gone, it can be difficult to get back on track.
Yeah. Okay, then. So I've got to stop the fizzy drinks. I literally water for 3 years, and never touched a fizzy drink because I was told not to. And
Yeah.
then 9 months ago, I had to take a sip of my husband's because I got a tablet stuck in my throat. Took a
Yeah.
sip to get the tablet down. I was like, that tastes nice. And then I'd have another one. That was it. Me back.
The problem with fizzy drinks, apart from the gas from our perspective, is that a
Mm,
lot of them have a huge amount of calories in them,
mm.
and people don't register the calories in them because it's
Even
not
the
food.
diet ones, even the Diet Coke.
Well, the Diet Coke, this is difficult because it's not so much calories, it's the additional stuff that goes into it, and the additional stuff that goes into it affects your metabolism. So the
Mm,
chemicals in all of this sort of stuff does affect your metabolism and your hormones in your gut. So all of these things are not ideal for you. Now, I'm
mm,
not saying you should not have these things, because you should have whatever you like, but having it in moderation and being mindful that fizzy drinks and bariatric surgery don't go well together.
don't mix. Yeah. I mean, to be honest, what I'm doing is, since I've sort of started again and mentally right to do this, I am going off it slowly. I don't think I can cut it out, straight away like that, but I
Yeah.
am going slowly down and down and down. And I
And
know
and
I'll be able to go back to water then because I
and
like my water.
that is the way to do it. If you go cold turkey, you'll almost certainly rebound, because
Mm.
that's what happens. So phasing it out
Happens
gradually
with
is
everything.
wonderful. So
Mm. And that's the
you've got the
same with
right mindset.
food. That's the same with snack.
Mm,
That's with everything, isn't it? Yeah, everything in
absolutely.
moderation. Yeah.
Absolutely.
So that's Samantha. Now, Adrian asked. I spoke to Adrian literally yesterday, and that's why I thought I would ask yourself. He's just come out of surgery, and so of course he's still got the drain, and it was filling up quite quickly, and he wants to know why. I know he's gone and dealt with it now, but somebody else, why did it keep regularly filling up again?
Well, what surgery has he had?
So he had the bypass, and then he had the bypass.
So it's very unusual to have drains after primary surgery. So we wouldn't
Oh,
routinely use drains. So if you have drains, it's often a sign that the operation has been complicated or difficult.
right.
Um, and if there's been a complication or a difficulty, then you need drains to monitor what's going on inside. And if the drain is draining nice, clear, yellowy fluid of
Then it's
relatively
fine.
low volume, then it's okay. That's kind of body fluid. But if you're seeing bile or bowel content or lots of blood, that's not fine. So definitely, if you've got a question about a drain after surgery, you must speak to your primary
He
team,
did, didn't he?
because
Yeah,
because who knows what went on or what
exactly. That's what I
literally.
said. Get to the
Yeah,
doctor now.
yeah, and
Now
I
the other
think if
what
you're having
was
large,
this?
I'm sorry,
Sorry, no, carry on.
I was just going to say, I think if you're having large volumes coming out, then that needs attention.
Okay, yeah, well, he did, thank goodness. What if it's a sleeve? Because the sleeve, obviously, people have the drain as well. Is that the same reaction, same thing?
We don't do drains. No, very very rarely do people have drains
Has the
routinely
drains?
for a
Ah,
sleeve.
so it
Some
is a
people
bypass.
some people would potentially put drains in just for security for a few days, but most surgeons in the UK at least would not do that routinely. That would
Mm.
not be a routine thing. It would definitely be a thing if it's a complicated or difficult operation.
Mm.
But the idea is enhanced recovery. So we want you to come out of the operation and get walking and drinking and moving straight away. And if you've got drains and catheters and tubes up your nose, you can't do any of that. So
No.
we don't do any of that.
Yeah. Okay, great. So Tanya asked, why is it that gallbladder operations are so common after weight loss surgery? That's
Well,
an interesting one.
it is an interesting one, and she's absolutely right. So gallstones often form after significant weight loss. So you don't have to have had surgery, weight loss surgery, to form gallstones. And often people who come to surgery have had that yo-yo dieting, the 5 stone off, 5 stone on thing. And often they have gallstones without realizing. So often you go into surgery having gallstones. But a lot of people will form gallstones because of the weight loss. There's a change in the bile salt composition, and your body will form these gallstones. 30% of people post weight loss surgery will develop gallstones. Not all of them will become symptomatic, and not all of them will need surgery. If you do need surgery, it's relatively straightforward. We can go back in, use the same holes as before, and take it out.
Okay, that's interesting as well, because that is a regular question as well. A lot of people ask that. A lot of people
Yeah.
speak to me about that. Now, Sandra asked, would she be a good? But I think we've answered that with the balloon, the tablet. Sorry, the pill. Sandra asked, would she be a good candidate at 22 stone? She's 5'3", but does she have to have a certain BMI? But of course, we've discussed that.
Yeah,
So,
I think 22 stone and 5'3" would probably put your BMI around the 40 mark. So she would be eligible for surgery on that criteria alone.
okay, yeah, yeah. And then Lily asked, when can she get pregnant after surgery? Because she's had the bypass and she's 3 months out.
Very, very good question. We
Who
definitely
asked that?
we definitely recommend that you wait 12 to 18 months after surgery.
Okay.
The primary reason is you don't want to be growing a baby when you are losing weight, because you want to prioritize the nourishment of your growing baby, not while you're in a weight loss phase. And it's very, very important after a bypass that you talk to your dietitian about pregnancy care, because you will need supplemental vitamins in addition to the ones you're already taking.
Okay, because it needs nutrition and everything, of course, to be able
It
to
does.
grow. Yeah.
So 12 to 18 months. Now, we have had quite a few patients get pregnant before that mark, and it's usually okay because we can guide you through it, but it does need intense monitoring by the team.
Yeah. Again, I've had somebody that did get pregnant before, and before the 12 months out, all accidental. But yes, and I think probably because she's lost so much weight, and then suddenly, obviously, you can get pregnant. Because I know she found it really hard before to get pregnant.
Well, fertility goes up hugely, and also confidence. People are feeling more body confident. People are feeling
That's
more,
true.
happy, and these are all reasons that,
In that way.
babies are made. I've just been passed a BMI calculation for that lady that you mentioned. It's
All
BMI
right, okay.
54. So
Wow.
that is definitely eligible for surgery on that basis. We don't know anything more about her, but it probably wouldn't be appropriate for the balloon, because
No,
the weight,
would have to be surgery.
yes, the weight loss with the balloon would not be sufficient.
Yeah, okay. So Nikki said, how many meals should she have a day, and how much should she eat a day? Because she had her surgery in January.
Yeah. So, I mean, it depends what surgery she's had, of course. But with all sleeve and bypass, you generally aim for little and often. So we sort of suggest that you should eat maybe 4 to 6 times a day rather than 3 meals a day. And it's about getting your protein in first. You have to hit your protein target before you hit your other target, because protein is what's going to give you muscle growth and is going to facilitate you feeling fuller for longer and therefore less likely to snack. So any questions around what you should be eating, etc., the dietitian and the nutritionist on the team should advise on that. But in general principle, aim little and often and get protein in first.
And how much protein do you have to have a day? Just let everybody know.
Well,
reiterate it.
I'm not entirely sure of the exact figure, actually, because it does vary depending on the patient and their individual requirements. But our dietitians would be able to tell you that.
As again, I forgot it is on the percentage and the person, and okay.
So there's not one rule for all. That's the very different. It's a very individual situation. And people have other health conditions. That some people have diabetes. So advising somebody who has diabetes is very different to advising someone who doesn't have diabetes.
So diabetes type 2 goes down quite relatively, doesn't it? So that's good. But type 1?
No, type 1 is not affected because type 1 is a primary deficiency in the pancreas, and that's something that you're born with. Whereas type 2 diabetes is your body doesn't respond to insulin, and that's because the fat-laden cells don't respond to insulin. So if you can make the cells responsive to insulin again, then the diabetes goes away. And there is a link between obesity and type 2 diabetes.
Yes, of course.
And surgery has been shown to put that into remission. So bypass is a stronger and preferred operation for diabetes compared to the sleeve, but both of them have been shown to put diabetes into remission, which means off medication.
I know. I've had a couple of friends that I've met through it, and they have literally come off it, and I'm just like, it's amazing. Is it better to have the bypass if you've got type 2 because it's longevity? Because I know you were saying about the bypass.
Yeah, so bypass is preferred for diabetes, and the reason for that is the degree of hormonal change that it can produce, because you need to have significant hormonal change in your body to make you responsive to insulin again, and the bypass is a stronger operation than the sleeve.
Right, okay. Just one question that I didn't ask you. Sorry, I didn't show you. With the sleeve, is it right that you actually take some sort of hormone and then with that taken out, it makes you less hungry? Is that right? Everybody's telling me?
Yeah, there's a hormone called ghrelin,
Ghrelin.
GHRELIN, which is growth hormone releasing inhibitor, to give it its full name.
Okay.
And that basically is produced primarily in the part of the stomach that is removed when you do a sleeve. So you have less ghrelin, and ghrelin affects your hunger. So you tend to be less hungry. That effect is strongest in the first year, but it's not exclusive. So there are other ghrelin producing places in your body. And hunger, of course, is not always down to hormones. It can be down to emotions. It can be down to behavioral stuff. So head hunger versus physical hunger is a real key topic.
Yeah, absolutely. Because obviously, like that. I understand that. Now, Danica said, oh, we've answered that because that's about regaining. She was asking how does she stop the regaining? But obviously what you're saying is that sometimes your body is saying, no, I want to be this weight, please.
Absolutely.
So she's asked about that, and we've said that. Now, Viv asked, I think this is the last question. Sorry, were you going to say something?
I was just going to say the key to considering weight regain is going back to basics. So looking at eating behavior and looking at the psychology around what's going on, and often regain is down to a loss of control in those aspects. People having slider foods, people emotionally eating, and there is no surgery that's going to make that better. So having surgery for weight regain is often a problem because the reason you've regained are still there. The reasons you've regained are still there, even after your revisional surgery. And revisional surgery is never as good as primary surgery because the stomach and the bowel are all scarred. So it's not as tight, if you like. So don't automatically think, weight regain, I must have another operation. That should be the last thought.
Yeah. I had the revision, as you know, and I maintained for the year because I just needed to get mentally right after the revision, for the revision, which I didn't. I now am, and totally understand that you've got to get mindset again. You've got to go down to basics again to get into your mindset, to go with your little knife and fork and your little plate again. Chew, leave it, and to get back to basics, basically.
You've got it.
Basically. Yep. So I have losing weight nicely, so it's working. And I'm sort of saying to other people as well now, this is how I've done it.
And that's very interesting, that your surgery wasn't working in theory until you got your head in the right space. So, when somebody has regained, focus on that first, because often you can get your original surgery working again. Now, a sleeve is slightly tricky because, once the food receptacle has stretched, you can eat more, so you don't have that. But certainly after a bypass, do not be going down weight loss surgery routes until you've exhausted every other possibility.
Yeah, that's it. Yeah, I agree completely, because I do feel that I either shouldn't have had it, or because I wasn't ready mentally, or I should have waited a year or just not had it at all and reset myself with the sleeve. But I had it. I'm here now.
And you're doing great.
And I am what I am. Yeah, and doing really good now. A year on, and I maintained. I didn't put all the weight on. I maintained and kept maintained. So
it's great.
I got here in the end. And yeah, just sort of, Vivian's just asked, Viv said to her, how after the operation, because she's going to have the operation, she's not had it yet, how long could she go back to work, exercise, and get back into normality?
So generally speaking, if everything goes well, we say it depends on your job. So if you can work from home, sitting on a computer, often people are working 3 or 4 days after surgery.
Wow.
If you have to physically go to work, as in drive a car or get on a bus, we say about 2 weeks. And if you have a very manual job where you're, lifting bags of cement or something, that's about 4 weeks post-op.
Yeah. Okay.
And a lot of people want the time off to recover. So I would always recommend you have the maximum time off. Give yourself and some people don't like their job, so we can sign you off for 4 to 6 weeks.
Let's take it off.
Yeah,
absolutely.
But if you like your job and you can work from home, actually, people can work fairly quickly. And we've had some patients who bring their work into hospital, and day 2 post-op are sending emails and what have you.
Yeah. Crazy. That's dedication.
Yeah. Good distraction technique.
I know. Yeah, absolutely. That's true. So basically, we've come back to the end of the questions. Is there anything else that you can think after all the questions that you think would help others or advise?
Well, I do a lot of educational stuff on my Instagram, which is also copied onto my Facebook, which is Weight Loss Surgery UK. But actually, Instagram, I think, is the primary source for these education.
Just reiterate, say it again. Which Instagram?
It's at Weight Loss Surgeon, and I do a lot of videos about things we've talked about regain, about reflux, about gallstones. So if people want to explore it in more detail, it's all there on my page at Weight Loss Surgeon.
Oh, fantastic. Yeah, that's really helpful. So they can either come back to here or they can do it all on Instagram. And I think that's fabulous. So we've come to the end. I can't believe it. That's gone around so quickly.
And
we haven't even got to the hour. But no, thank you so much for coming on. I really appreciate that in your time, in your schedule. So that's really nice of you.
No problem.
So
It's
I
been a
will be
pleasure.
speaking to you on Instagram. Anybody can speak to you and catch up with you on Instagram. Is that right? They can message you
Yeah,
and
no
follow
problem
you.
at all. Yeah.
Yeah, if they've got any more questions. And obviously, if they ask any questions here on YouTube or any of the other platforms that we're on, then I'll bring it over to you and you can, or I'll send them your way.
No problem. I'd be delighted.
All right, my dear. Thank you very much for coming on. And
Thank
I
you very much.
will, yeah, that's all right. No problem. I'll speak
Thank
to you
you.
soon.